Welcome to Between Two Psychs, a podcast where two psychologists and board-approved supervisors deep dive into many of the questions and challenges that provisional psychologists and early career therapists face in everyday practice, during training, throughout the internship, and beyond as they progress into working more independently. Your hosts, Isabel Tombleson and Claire Trevitt, talk about a range of topics, specifically relating to psychologists and therapists who are just starting out.
Morning, Claire.
Morning, Isabel.
It's nice to see you today.
It's lovely to see you again too on this very rainy morning in Sydney.
Yeah, it's rainy up here too.
Yes.
But I'm really excited about today's episode. Do you want to tell everyone what we're going to be talking about?
Sure, yes. Today I'm going to talk a little bit about psychodynamic therapy, which is a therapy that I trained in the early 2000s. It was around 2006 for me, by which point I'd been fully registered for 4 years. And how I got into this was like most psychologists, I trained in CBT, and I actually received some really good training in CBT. My employer sent me on some 2-day workshops, some 1-day workshops. I think in total I did about 6 full days of training. And so I felt like I had a really solid base. But I felt like I wanted something a little bit deeper, but I couldn't really put my finger on what I meant by that or what that was even going to look like. And I was just talking to a colleague one day who had trained in psychodynamic therapy, and there was an opening in this particular training that they had done run by a community-based organisation. And I jumped at the chance to get involved, and I just haven't looked back since. So I completed about 6 months of theory. It was at weekends, full days over the weekends, full Saturdays, of just the theory component for 6 months. And then I saw 2 clients for 2 years, those same 2 clients for 2 years under supervision, where I would take, very detailed notes. The same clients in a group setting, and so we all would take the same cases, and the clients knew that we were under supervision, and it was part of the arrangement. And it was a great service because we provided counselling to people who couldn't otherwise afford it, so it would be a very nominal fee, and but people would get access to long-term counselling, as in a minimum of 2 years.
Wow. I'm not sure if I even have heard of anyone doing counselling or therapy with people for that long period of time in the experiences that I've had. That's so, I'm so excited to hear more about this. Sorry that I'm interrupting you, but I'm just like, wow. Keep going.
No, that's good. That's good because it's it's actually good to have this conversation with you. And I'd like to sort of answer any questions that you might have, because I'm assuming that listeners might have similar questions around that too.
Well, for sure. I mean, the pathway that you studied psychology under, the 4+2, that's been phased out now, but 5+1s and clinical master's pathways and the other, postgrad pathways for psychologists, it's still a huge focus on CBT as the gold standard primary intervention that we're all trained in. And if we have other therapists from other professions listening to us now, I'm not sure if CBT is what you're mainly being trained in, but I just know that in my world it's always been about this sort of shorter term, maybe 12 weeks, and always thinking about the Medicare funding. It's the language that we're taught. It's the foundation that we're taught. Well, tell me more about the group. You were describing how it was part of a group. I wasn't sure what you meant by that.
So it was a supervision group that we attended fortnightly. We would see 2 clients each as therapists, and each therapist would then choose which one of those cases to present at supervision. but we all got to know sort of each other's cases in depth as well, and follow those over that period of 2 years, and really begin to see that that transition for the client. So, and as you can imagine, it's quite a I mean, I say it's a slow process, it's a lengthy process, but it's not always slow. There are certainly periods of growth that can occur quite quickly, and then others that can take time. You don't necessarily put a time limit on that, because the understanding is that it's going to be a longer term process.
And where does that understanding come from, if it's okay for me to ask that?
Yes, well, so psychodynamic therapy really is around making the unconscious conscious. And so in order to be able to do that, we need a little bit of time and space for things to unfold. And so historically, in traditional psychoanalysis, the training, and even today, I believe the training is a 4-year training. And throughout that training, the therapists themselves undergoing the training attend therapy 4 times a week for 4 years.
That's so much.
It's so much therapy. And it's typically not so active in that sense. A traditional psychoanalysis would really be somebody lying on a couch and the therapist listening, and there'd be some reflection, but there would be almost that sense of the blank slate, which is that very traditional psychoanalytic perspective. Now, it's not like that now, because we don't have the time and we don't have the funds necessarily to be able to afford to do this. I mean, you'd have to be pretty financially secure to be able to even do that type of lengthy training because of the therapy, not to mention the supervision and also the training costs that are incurred with all of that. So typically psychodynamic therapy mostly nowadays would be once a week. And it would be face-to-face, so there wouldn't necessarily be that couch with the therapist looking at the client. The idea being was that the client could enter sort of free association and there wouldn't be that sense of distraction. The therapist tends to be much, much more active now. And so when I talk to my supervisees about psychodynamic therapy, and I've run some trainings on psychodynamic therapy, I more think about the principles and how we can integrate those into the work that we're doing, regardless of the therapeutic modality. So although the training is quite extensive, I believe that we can apply psychodynamic principles into the work that we do, because it's so very, what I would describe as relational. It's really about the client and the therapist having a relationship, a different type of relationship, but a relationship that plays out and also forms part of the treatment, in the sense that we'll talk about what's happening between the client and the therapist actually in the room, how that might replicate other aspects of their lives, for example, which would be what we'd call transference.
Yes. So I think when I've had supervision from my wonderful supervisors who are very experienced, especially working with personality disorder, being taught about transference, countertransference. So that comes from psychodynamic?
It does.
Okay, great.
Yeah.
I'm thinking about that and being like, oh my gosh, that's what's happening. Why, noticing when I'm feeling really anxious going into a room, is that just me or is that them transferring onto me? All like those insights were so helpful for me when I was in my early career, that it's almost become kind of instinctual now that I put on my little spidey senses when I'm in the room with people, so that I can use that therapeutically. Is that sort of?
And I think that lots of us are doing that anyway, even if we're not necessarily calling it that. It's what happens in therapy. So yes, I do. I think that you would most definitely be doing that, even if you're not calling it transference.
Yeah.
You would be thinking about the impact of the relationship. And that's what I mean about how it can be so, I think, integrated quite easily into whatever style of therapy using.
Okay.
So I'm wondering whether maybe I might talk a little bit about the goals of psychodynamic therapy.
Yes, that would be great.
And then I might talk a little bit about some of the techniques, strategies, including the use of transference, to sort of provide a little bit of an overview for people.
Yes, let's do that. That sounds amazing.
So the primary goal of psychodynamic therapy, as I mentioned earlier, is to really make the unconscious conscious. And what we're trying to do is to recognize and identify patterns in our feelings and emotions, our behaviors, and our relationships, because these just play out pretty much repetitively in different parts of life. And so clients might come with difficulties in a relationship, and they might just find that this plays out over and over again in their lives. And so we're wanting to identify what is happening unconsciously. And once we can identify what's happening, it's then much easier to say, okay, what are we going to do with that information? And sometimes the insight in itself can really make a huge difference. So it really is about promoting insight. And the other thing that we're doing, because it's focusing often on what's happened in the person's life, we are very much interested in what happened developmentally, what happened in childhood. And so we're wanting to identify and address any kind of avoidance that might be occurring, or any kind of blocks that might be occurring that might have their origins much earlier in the person's life, because essentially we learn strategies to navigate life and perform quite early. And I'm sure as I'm saying this, people might be thinking, this feels quite consistent with other things that you've learned, and it probably is.
Yeah, I'm thinking about schema therapy.
But schema therapy very much would have some of a psychodynamic slant, most definitely. Yeah. The other thing that we're really wanting to do is to strengthen the person's sort of ego, their sense of self. And so, through that sort of uncovering of unconscious processes, and through identifying some of those blocks and avoidance or resistance or defenses that a person has developed in terms of their coping mechanisms or their survival mechanisms, sometimes that involves them putting themselves to one side, not necessarily really putting their own needs first. And we're wanting to really get a person's sense of self strengthened, so that they can begin to work in their own interests and meet their own needs. And again, that's probably very consistent with a lot of other therapeutic modalities. So ultimately, we're wanting to gain an insight into how the early experiences impact the present behaviours. And through the relationship, we're trying to provide a corrective experience. So the relationship becomes a healthy relationship, maybe in comparison to some relationships that were not so healthy earlier on in the client's life. And so if we can model that healthy relationship, which can take time, then that's obviously going to have a flow-on effect into other relationships, because the person's hopefully going to begin to expect a little bit more and to understand what it's like to be in that sort of healthy relationship dynamic. So although we're trying to reduce symptoms, and I think as psychologists, we sort of, we're all about symptom reduction. That's only part of the goal. Really, we want the individual to understand themselves and to live a much fuller life. And that's where the time frame comes in. Because we have such, I guess, ambitious goals here, we need to be realistic about how long that might take. And so a short-term psychodynamic therapy would be around 40 sessions.
Wow. And so if you're, doing psychodynamic therapy with a client, I suppose you'd have to you would communicate that up front, and do they sign up to 40 sessions? How does that work?
Yeah, I find that, I can't always expect somebody, if they've come through, say, a Medicare care plan, to be signing up for 40 sessions. And it's also a lot of sessions to be signing up for initially.
Mm.
So I would probably say to people something along the lines of, I'd want to assess whether or not they have a capacity to fund their own therapy through the Medicare model and whether that's going to work. Because I don't bulk bill, and so like most psychologists couldn't afford to bulk bill. And so there is a co-payment, and if that co-payment feels manageable, I might say to clients, look, you get 10 sessions a year through Medicare, and that seems like a lot, but actually it's 10 hours and that can go very quickly. And so if you did feel like you wanted to stay for longer, there's the possibility to do that. And I sort of gauge their response to that. Some clients will say, well, let's see how we go. Other clients might say, I really can only afford the 10 sessions. This is going to stretch me, even just paying the co-payment. And other clients will say, you know what, I'm probably where it's going to take longer than that. There's been a lot that's happened in my life, and so I don't want to rush.
Just on that note, what you described there, that person who says, I've had a lot happen in my life. I know there's a lot that I need to process, that sort of awareness. That's, I guess, now where I'm seeing psychodynamic therapy being really helpful, that a person can have a professional who is able to say that they will be there for them for a long time, and working around their financial needs and that sort of thing. It might not be 40 sessions in 1 year. That might be spread out over 5 years or something. But this idea that there is a therapist whose training and practice aligns them with being committed to being a stable person, who can privately, confidentially hear the story of a person's life and sit with them and allow them to process their story, their narrative. And I guess, like you said, the goals of psychodynamic therapy being to use the relationship to help them to heal and provide a corrective experience. I guess the person has an opportunity to be heard and just not be judged. And unless we've got a really magnificent family member or non-judgmental, perfect partner, or or a really, really good friend, we don't always have those opportunities in our lives to just be heard and not judged like that. So I can think of clients who would just benefit from this so much. And there's the areas that I've worked in government and non-government organizations, but being government funded, it's there's just no consideration of the benefits, how beneficial it would be for someone to be able to have a therapist long term like that. It's all about just get them through the door, let's get some symptom reduction, and we've got too many people for you to stick around, I've got to get to the next person. Yeah, it's just counterintuitive to probably what the real needs are of us human, real people.
It is. I think that is one of the difficulties with the very short-term model, because often I think people they can go from service to service, and they might access a short number of sessions. A sort of shorter term therapy model, that's 6 sessions or 10 sessions. But they might access a large number of sessions over a period of time, over a few years, for example. But if they were to be given that level of consistency, then, I think that, I think about clients that I might have seen maybe fortnightly over a few years that maybe were in crisis and really, would present to hospital maybe fairly frequently. And just the sense of reducing those hospital admissions and somebody returning back to work, and the financial benefits of those things, I think, doesn't often get considered. And I think that if longer term therapy was to be funded and we were to think about the financial advantages for people, potentially it could be really cost effective. because it probably costs a lot of money for, I don't know what the costs are exactly, but for somebody to present to hospital and for somebody to be out of work for a long period of time. And then when I've worked with people who are not working, and then they get to a point where they say, look, I'm well enough, I'm going to go back to work part-time, and gosh, that makes such a difference to their self-esteem. And then, of course, they begin to contribute financially back into the system.
Yeah.
And it can, I think those cost benefits can often be overlooked. So I do think that, I mean, I would love to see, but of course, this is what I'm trained in, and this is what I think, we could all do with.
You have a slight bias, but I think that the psychodynamic theory would be able to back up a rationale for at least somehow supporting a model where a client is able to come back to the same therapist at a minimum, because you hear that all the time in our health system. I'm sick of saying the same story over and over and over again. Gosh, you hear that so often. And so psychodynamic theory probably talks about the importance of the stability in that attachment relationship, that corrective experience relationship. People have to start all over again, when they meet their next clinician.
Unless they've got the same clinician that they can return to for their 10 Medicare sessions every year, or space them out monthly or something like that.
Would argue that could be better.
Yes, I mean, I would agree that if a client has seen a therapist in the past, I will always ask them, they come to see me, I'll always ask why they're not going to see that person again. Because I tend to think that if you've got a therapeutic relationship, and often it'll be, they retired, or, they left the practice I was working at, and, or they were relocated somewhere different. And so that, for that reason, I would think would feel, I would make sense to go and look for someone else. But it also, sometimes people do struggle to connect, because although that's the focus of the work that we're trying to do, we're trying to create that solid, I guess, secure base for that attachment relationship. Not every client is also going to, blend into that so easily. They're going to find, some clients will find it difficult if they've been let down in the past. They feel like they're getting too close. They might feel like, and these are the different attachment styles, of course. So, but in terms of the efficacy, because we tend to favour the short-term models, and the psychodynamic therapy has been listed as having level 1 evidence for the treatment of depression and borderline personality disorders. And that was through a publication by the Australian Psychological Society in 2018. And it has level 2 evidence for a range of other disorders, eating disorders, adjustment disorder, generalized anxiety disorder. So there is some evidence, but of course, being a longer term model, it's more expensive to fund. So, and there was also a really interesting study in 2006. So it was an analysis of 23 randomized controlled trials, where people had short-term therapy, so that was less than 40 hours of psychodynamic therapy, with a control group versus either no treatment or minimal treatment. I'm not quite sure what the minimal treatment was. It might have been sort of 4 to 6 sessions. And so the results did show an improvement in symptoms. But what was really interesting was a follow-up 9 months later showed even more improvement. So that suggested that even after therapy finishes, the benefits continue.
So how you started off the episode talking about how you were interested in getting a deeper understanding, I guess, of psychology or the human experience. That evidence you were citing there speaks to me about maybe the psychodynamic therapy working on a little bit more of a deeper level, maybe that unconscious level that has that maybe then has longer term benefits for a client, because, you know, we're not working from the top down, just, you know, on our everyday cognitions, you know, doing exposure therapy and things like that, that probably need a lot of repetition and practice. Yeah, there's maybe when we're accessing things on a deeper level, on a more unconscious level, they probably help people for longer.
I think that's probably why there's a level 1 evidence for depression and borderline personality disorder, because these are often with these two presentations, there's a sense of sort of emptiness or a sense of hopelessness that can present. And of course, with a solid, secure relationship, you know, over time, there can develop that sense of trust, and that sense of hope. With another person. So I think that partly what the relationship does is it creates that sort of ability to create a little bit more meaning for the individual, but also a lot more scaffolding and support, which is often the cause of a lot of the low mood, a lot of the dysregulation, sort of feeling as though no one or nothing is there.
So it's, I'm hearing about the relationship between connection with people in our lives, and a lacking of that connection, a meaningful, you know, really authentic connection, and how, you know, the psychodynamic therapists, you know, uses the therapeutic relationship to heal, I guess, to model how to have those relationships, and maybe to heal some of the barriers or blocks or defenses that have created, that have contributed to a person not being able to have those authentic connections. You're almost sort of coaching them on how to do that, I guess.
Yeah, and modeling that absolutely. And that's where they're, in terms of I guess, techniques. I mean, the first one is this free association. So one of the things that's quite unique about psychodynamic therapy is there's no agenda. And so when the client walks into the room, they set the scene. And so really that's where, I guess, the sense of a blank slate comes in. As part of my training, I also had quite an intensive therapy experience myself. So I actually attended therapy twice a week for a number of years, and which was in some ways the best sort of learning for me, because then I had that modeling of how that therapy plays out from my own experience. And my therapist said nothing when I walked in the room, nothing at all. I mean, and I got used to it very quickly. It was me, I started the session. And so I try and get my clients to start the session. You know, they'll come in, how are you? Well, we're here for you. And redirecting their focus back to the client. And really, I can say anything that they want to. And it's not about me saying, you can say whatever you like here, because if I said that, I'm not sure how much permission clients give themselves for that, if that makes sense. But I would give them permission to say whatever they like. But I guess in doing so, I just stay as quiet as I can and allow the client to start and think about what happens. And if they say, you know, those awkward silences when a client walks in and they don't know what to talk about, I might say sometimes it's hard to get started.
Wow. So neutral, so just like not about you at all.
No. It's and also not having an agenda. You know, oh, how did this go? How did this go? If they come in and say, oh, I've been wanting to see you and tell me about this, then I might say, oh gosh, I was thinking about you. Yes, let's talk about that, because that's what they've come in to talk about. But I try not to start with my agenda, even if it's associated with what the client is, what's happening for the client.
Wow.
If they've had something happen on the way, or they've had a difficult interaction, they want to just get straight in with that. And the unconscious will guide this is where that trust in the process, the unconscious will guide that. And so you're always looking for a sort of thread of meaning even if the client's talking about so many different things and meandering, we're just looking for that thread of meaning, because of course it's not just about talking aimlessly, but to think about what's the theme here? What's the client really trying to tell me?
What's the message or the meaning?
Yes, yes, yeah.
Wow.
And then reflecting on that can, help the client gain a deeper understanding. So that's the purpose of free association, not to sort of just meander and say and allow the client just to talk out endlessly, but to try and create some sense of meaning and a thread and theme for the session.
You're reminding me of when I used to work with a cohort of a particular population of people, and I won't describe anything more than that. But I remember I needed to use a technique like that because I learned that, the population of people I was working with were just, for some reason, really averse to any other style that I tried to use with them. And so it was really just about letting them be in control of the session, and then I would just try and make connections between what they were sharing with me and reflect meaning a lot and try and reflect feeling, and that's how I used to make it work. And I think that was just me trying to be creative and a little bit intuitive about how to be adaptive to a really different, unique population of people that I was working with for a short amount of time.
And was it effective?
Yeah, it was. It was amazing. I still think about those clients now. Yeah. And it was a sort of long-term setting as well. We were working in that area for 12 months, and so I was seeing people for a long time as well. And I think we were both aware, that we're going to have to spend a lot of time together. This is a 12-month thing. And it's just amazing. I completely forgot about that experience, but hearing you talk about it has just reminded me that, there was this thing that I did one time, and it was this long-term thing, and it was very intense, and there was a level of like coercion. My clients didn't want to be there, and so therefore the traditional style didn't work. I had to totally throw that out the window.
But actually, one might argue that this was quite a traditional style of therapy.
Yes. my CBT traditional style. Had to get
yeah. And there's something about taking the pressure off the time frame as well, I think, because I think that this, even when I do have a client, I think, okay, I'm maybe only have sort of 6 to 10 sessions with this person. I'll probably still work in a similar way. I might be more directive, but these principles would still apply, because I guess it's ingrained in me in a way. And then, so there's some other, I guess, techniques. Another one is like interpretation, which is ultimately where you try and make connections between the here and now and the past. So there's a sense of, okay, well, you might be feeling this way now because, this was your experience in the past. And so which is called interpretation. And it's a way of, I guess, developing understanding. And of course, there's a full technique to that. But the process is really around trying to make these connections, but also communicate those in a way that the client can see, because it's about, actually, I'm not in the past anymore, but I'm responding as though I am. And it's that gentle sort of reflection that creates the insight for the client to then, get more awareness of what's happening. And hopefully that will, over time, begin to generalize.
So I'm trying to think of an example. So let's say we have someone who has a, cluster B personality traits or something, and their experiences in childhood were, that their feelings weren't important, and maybe there was insecurity in lack of safety in their attachment relationships, and then they go on to have relationships as adults, and experiences that they have when they're relating with their intimate loved ones as adults are reminding them of how they felt when they were smaller. And so their reaction and their feelings and the things that they their coping behaviors that they use to cope with those feelings, you might sort of draw a connection between that and how they felt when they were littler, so that they can maybe like see that it's not so much the experience or the thing that's happening to them now as an adult that's causing the emotional response and the behavioral response. It's those memories from back then.
Yeah, absolutely.
And then all of a sudden it's like, oh, that's why I'm doing this. That's why I have a hard time when this happens to me now. And then you said, hopefully, like as you continue to make space to explore that with someone, those insights deepen, and then hopefully it starts to weaken those automated responses.
Absolutely, yeah, and it might take time and repetition, but yeah, it's and there's a sense of readiness. There needs to be a readiness for the client to hear it as well, for them to be able to. They're not always ready to hear that interpretation.
Yeah. Okay.
But when they are ready, it can be really like a big light bulb. It's, oh my gosh, that's why I'm doing it. It's create a level of insight.
How would you know if someone was ready to hear that? What would be the sense that you'd have from them, or the feeling that you'd have in the room?
I mean, we can't always know for sure, of course, but we might just trial something. So I would trial something maybe that was less prominent, because if you miss an interpretation, you might have to wait, and they say, no, that's not the case, and it was something quite prominent and important, then you've missed an opportunity. So we don't want to do that. So you might just try something, gently. And so they might say, oh yeah, and I was waiting in a queue, and I had this feeling, and it might say something like, oh, it sounded like that reminded you of that time there. Yes, it did. And you think, aha, they can make that connection. So we want to try it with something very gentle and not so prominent, first of all, so that we can get a sense of the client's ability to connect past and present. And then, once we've got a sense of that, we might begin to do that a little bit more. It's quite specific to psychodynamic therapy, and I know that some of the trauma-related therapies that I've been doing more recently, particularly in somatic therapy, very much they don't use interpretation at all. And there's a sense that we're not trying to interpret, we're just trying to see what's there. And so it is quite a specific to sort of psychodynamic in terms of that building insight. And it's not necessarily endorsed by every model of therapy, but it's certainly something that I was taught to do. Because you might hear people listening might think, but I was taught not to do that. And that's okay, because we don't have to follow everything. We follow what feels right. Sometimes I'll interpret, sometimes I won't, depending on the situation. And so these are just sort of techniques that can be used and can be really helpful.
Can I ask a question? So you mentioned before about the attachment relationship that you might have with your client, and you were talking about how sometimes there can be like a distance, or sometimes there can be a closeness. And so I'm thinking about boundaries, and I'm thinking about how close do you get when you're in a psychodynamic therapy experience with a client, and how do you know if you've gone too close? How does your mind help you with that?
So one of the things about psychodynamic therapy, which is, I think, really important, is the therapeutic frame. And so I think about the frame being like a boundary. And when we think about developmentally, a newborn baby likes to be wrapped up. So newborn babies love to be wrapped, but not too tightly and not too loosely. It's got to be just right. So they've got to be held and contained. And so I think about the therapy space as being containing and holding.
Mm-hmm.
And in order to be able to do that, we need to be reliable and consistent.
Mm-hmm.
And so the frame would consist of sessions that are consistent, which means the same time, on the same day, each week or fortnight, and in the same therapy space. So I worked in a practice once. I hired a room in this practice, and my second week there, they put me in a different room, and I said, oh, I can't be in a different room. I have to be in the same room. And it took a little bit of explaining, but I said, and they said, well, but this room's a better room for you. It's got a window. And I said, I do appreciate it. It's a nicer space, but actually I'd rather have any space that's the same, because they were all adequate therapy rooms, because my clients would come in and say, oh, we're in a different room today. And it would feel unsettling right from the start. So in terms of the boundary, we create those very clear boundaries. We start sessions on time and we finish sessions on time. So the client knows what to expect from us. And if we do then get clients calling in between sessions, it becomes a lot easier to manage, in the sense of, and I would say to a client, look, if you call me in between sessions and I don't answer, and I'm not there for you in the way that you need me to be. But if you come to our session at the agreed time, I will be there. And I will be there reliably, and you can have that space, and no one else will have that space. It's just yours. And that becomes the boundary, and it becomes containing, and it does become quite fixed in a way. Not in a kind of rigid way, in a helpful, containing way. And so the idea is to try and bring that consistency. So the clients that will struggle to not have that contact outside of sessions, those clients that, really have that need for connection, actually, when they do keep reaching out and we're not there, it exacerbates that sense of emptiness and loneliness. Whereas if they can wait until the session, they can have what they've come for, and they know it's going to be provided. And so there's a bit of psychoeducation that can go on around that can really help people. But when they know that that's theirs and no one else has got that space, it's something really, really containing for people.
Okay. And I suppose in terms of, like, within the therapy sessions, would it be normal to expect a level of like what I like to sort of think of, like a real serotonin inducing experience, like when you've got a good rapport and the client is feeling safe, and we're able to help a client to make those deeper associations and make the unconscious conscious, and we're noticing that there's like that warm fuzzy feeling. Am I right that that's what we're aiming for in psychodynamic therapy, and that's appropriate? Or like, and I'm just thinking about, because sometimes, like, I want to be careful with my clients to be a little bit guarded with going into that warm fuzziness too much, because, well, I know I'm only able to offer them a really short amount of sessions, and and I'd love to be able to still be there for them next time they need to come through the service, but I can't promise that I will be. And so, yeah, I'm just kind of like wanting to compare how the majority of us are probably doing our work, and in a time limited sense, we might have our guard up a little bit, because we don't want to help, like, I guess, offer the client that corrective experience where they maybe finally feel heard and accepted by someone for the first time, and then, okay, like, we're finished now, like this sort of thing. But yeah,
that's such an interesting question. I think it reminds me of when young babies were placed in, this was when children were, prior to, say, foster care, were placed in sort of infant homes or orphanages. And there was a tendency for the staff to rotate, I think it was every 6 weeks, to reduce dependence.
Yes. Oh, those
Um,
poor children.
and so it was felt that it was better to have a solid attachment experience, even if the staff member was to leave. So if somebody was consistently on the staff for 3 to 6 months, but then they left, because the idea being was that when the staff left, then that would create dependence and it wouldn't be good for the children. But what was found is that that was actually, it was worse, because they developed that dependence over the 6 weeks, and then it would change, and they'd never ever get that consistency.
And then there would be like, they wouldn't be able to trust again, you know, they would feel abandoned. Yeah.
And it was a cycle that sort of would repeat over and over. It's better to have the experience for as long as it lasts, and for, even if there is that staff member leaving after 6 months, or even after they're leaving after a year, it's better to have as long as you can get.
Okay.
And rather than that rotating,
Yeah.
unnecessary.
And that coldness as well.
Yes.
You can sense when someone wants to be distant from you. Clients are so good at picking up on that, because, you know, of their own experiences.
Absolutely. And so I hear this so much in supervision, this question of, will my clients become dependent on me?
Yeah.
And people worry about that. And I don't worry about that at all. I don't think my clients are dependent on me. There might be a period of time where the therapy feels important, and therefore it is part of their routine, and it feels like they need it at that period of time. But I think that's probably the same for any client who's coming to therapy in any acute stage of distress. But I don't worry about a client becoming dependent on me, because, well, first of all, I'm prepared to offer them the therapy for as long as they want it or need it. So my door is always open. If a client says, I'm going to take a break, I'll say that's totally fine. You're welcome back anytime. I can't guarantee you the same time and space, but I can guarantee to you that I'll do what I can to see you again. And so there's this sense that they can always come back to me if they want to, that I'm there and I'm going to be constant. And that's what I've always tried to do for people. Coming back to the warm and fuzzy, I mean, at some level, we do want there to be that sense of connection and that sense of being held. At the same time, though, we're also going to be humans, and we're going to, at some level, let our clients down, and we're going to have to probably wear the fact that that's going to happen at some point. And that's where the countertransference and transference comes in, whereby if a client that comes in and says to me, I've been let down by so many therapists in the past, and, you know, people would do this and people would do that. And I might actually say quite early on, you know, there might be a time where you might feel I'll let you down as well. And if you do feel like that, I want us to talk about that. I want us to really, you know, think about that and think about how we can get past that, because a corrective experience is not about being a perfect experience, but it's about being a healthy experience. And so if there's a rupture, we can repair that. We can get past that. I might let you down, and whether I mean to or not.
But I'm going to be big enough and adult enough to be able to have a conversation with you about it.
Yeah, and I will still be there for you. And if you're angry with me, whether it's valid or not, sometimes clients get angry because something else that's going on, I'm still here. I'm still hearing feelings. And, you know, as long as it's not abusive or dangerous, you know, if a client gets annoyed with me, well, you know, they've got a right to their feelings, and I'm going to clear that out and see what I can do to help that. So sometimes we have to be prepared to work with quite strong feelings. That's different to saying, I mean, I won't be abused by people, but I find that's never really happened.
I can relate to that with that population of people I was mentioning before. Very, very strong feelings in those therapy sessions. Oh my gosh, it's like facing a tsunami of emotion, but at the same time, you know, and massive efforts to restrict their emotion as well. It was amazing. Yeah, really. interesting to think back on that that time. Yeah.
And so a few other I guess sort of strategies that we would use would be we'd look at different defenses that clients might put into place, different strategies. And I guess that might align with, I mean, it's not the same, but it, in terms of the cognitive distortions or different schemas, it's different ways that clients kind of keep themselves quite strongly protected. So that might emerge over time. And the idea is to explore and examine the defenses. And then finally, there's transference and counter-transference, which we talked a little bit about. Transference is when the client would evoke feelings in the therapist from somewhere else in their life. So inadvertently, I might say something in a certain way, and I might remind that person of their mother. That's not something I've intended to do. I don't know their mother, but they might react to me in a way that I was their mother. And if that situation arises and say, well, maybe the way I said that or what I said might have sounded like something your mum would say, and they might agree. But me naming that then helps the client see that I'm willing to acknowledge that. And then to see that actually I'm not the mother, I'm somebody different. And so being able to draw on those, and it's inevitable that that's going to happen. And the same way that, I might evoke anger or frustration or disappointment, not meaning to, but this is what happens in relationships. We do evoke feelings in other people. And if we can repair it in the therapeutic relationship, well, that then gives hope for repairing in other relationships.
And it gives like a bit of a, like you said, it models a way that can be done by you demonstrating it. You're unconsciously teaching those skills to your clients.
So just modeling so they can experience it. They can feel what it's like, and it's very much in the here and now. Even though it's a therapy that focuses very much on the past, we're actually very much working in the present, in the room. And then counter-transference is when the therapist experiences a feeling that in relation to the client, and that can be either in relation to the client's experience. So I might sit there and think, I'm really struggling to I'm really struggling to connect with this person. I wonder whether other people struggle in the same way.
Okay.
And so that's giving me information about that client and thinking maybe that's why they're struggling in relationships, because I'm experiencing this too. So it becomes useful information. Or counter-transference can be a response that I have that's actually in relation to somebody else. So a client might say something and I think, oh, I didn't like that. But I didn't like that because it reminded me of something that happened for me.
Oh, wow. So, that reminded me of so-and-so from my own life.
Absolutely. And that can really happen. And that's why in psychodynamic therapy, we're encouraged to have our own therapy, because when that happens, that isn't to be brought up in the therapy room. That's for me to take somewhere else. Ideally, if I can catch that, and I do catch it, it happens often. And I think, okay, I've got to put that somewhere for myself. I'll go away and think about that so it doesn't come back here, because that's not going to be helpful. But any reaction that we have in the therapy room is really it's important to listen to.
I've kind of developed this awareness that it just because we're not verbally saying something and purposely communicating something, it doesn't mean that our clients can't sense that we've had an internal experience. So I believe our clients pick up on our reactions, our subtle internal reactions, because we probably don't realize it, but somehow we probably are having a facial expression change, or like a shift in our energy our fight or flight response, or autonomic nervous system change, or a feeling. I think that, they're very good at all humans, I think, are very good at sensing those things. Transference or a countertransference, like you're saying, first of all, like awareness would be the first step. I've had this thing. Let's park that. I'm aware that that's probably my stuff because it's, reminding me of something from my own life. But then you would also have to bring yourself back into the room somehow and then regulate your autonomic nervous system to come back into that, non-judgmental empathic space, wouldn't you?
And I think that's partly why having our own therapy can be so helpful, because when that does happen, I know it's usually something that I've worked through or that I'm aware of anyway. So it's not necessarily like it's a brand new thing. I think, that's that.
So it doesn't rock you. It doesn't, it's not like a jolt, to the nervous system sort of thing. It's like, oh no, hello, old friend.
Yeah, because I've worked through so many of my own experiences that I'm aware of so many of them.
I can only imagine what that must be like. I can't imagine what that must be. I mean, I think as therapists, if I'm pretty sure most of us, having gone through 4 years of studying psychology and then now 2 years of whatever training pathway, most of us are probably aware, would have some insight about our own experiences just from the learning that we've undertaken. But actually going and seeing a therapist for that amount of time would just deepen it to a whole new level that I can't even imagine.
It is, because you know yourself better. That's what I came away with. I just know myself better. And my experience was similar to the research. Is I feel like, even now I have this internalized sense of the person that I saw, who was so solid, so grounding, and so in my corner, but also not frightened at all to pull me up on things. Brilliant combination. And sometimes now, if I'm facing something tricky, I'll think, what would he have said? And I can just picture him immediately, just how he would be, because I was with him for so long.
Wow. I want to touch on something. So I've got my, previous to us doing this, I had my little YouTube channel, The Psychologist, within. That's where I got the name from. So I realized that, I've had my own therapy as well. And to this day, I think about, those therapy experiences and those therapists and some of the standout moments with them. And I remember thinking to myself one day, I wonder what she would say if she was here and I was talking about it. And then I'm like, oh my God, our clients are probably doing that too. There's a part of us that goes away with them, that's, internalized in their memory network. And I love that idea that maybe it starts off with us being the psychologist within, but then it becomes their own psychologist within, like they internalize their own therapist, their own voice rather than being our voice, sort of thing.
Yeah, we want the client to begin to internalize that experience so that they can then have the experience that they have in the therapy room outside the therapy room. Take the good stuff away.
Yeah, for it to generalize and carry on. Yeah.
And I think these are principles, which is why I was thinking of them as principles that we can apply in our work. We don't need to do an in-depth training to be able to apply some of this into the work. So people that are interested in psychodynamic therapy, you don't have to go and study it for 4 years and go into therapy for 4 years. But you can begin to introduce some of these ideas. And I think schema therapy does very much blend some cognitive, some psychodynamic, ideas and concepts, and other therapies would as well.
Yeah.
And so, but I think for me, it's about the relationship that I have with my clients. And I find I have a very transparent relationship. So sometimes I'll think, gosh, that wasn't a good session. And I'll come back the next week and I'll say, I just want to check in with you about, after the client has, of course, got used to, introduced their own sort of topic to the session. but I'll bring it back in where I can and say, I just want to check in with you on something that we said last week, and I was wondering how this landed for you. And sometimes they'll say, oh, that was fine. And other times they say, yeah, that was a bit, whatever. I did feel it was a bit jarring. And I'll say, I reflected on that, and I'm sorry that was, that obviously wasn't what I meant it to be, but that's obviously how it came across, and I was just reflecting on that. And so sharing transparently my own process with them as well in relation to their therapy can sometimes also bring up things they wouldn't necessarily have been thinking of as well. So I do tend to be very reflective in my approach.
I like that transparent and reflective sort of note there. And I really like how you shared with everyone that, yeah, we don't all have to go, if we are liking what we're hearing today, we don't all have to go and do an intensive psychodynamic training course or psychodynamic therapy ourselves. But there are principles that we can take forward into our own practice. I'm sure there's some wonderful readings that we could do that would be available online for free. You've got your training course that you do in psychodynamic therapy. And then, yeah, also just kind of noticing when we might be being given training in other modalities like schema therapy, just paying attention to those overlaps and noting, potentially that majority of the therapies that we're trained in probably, were based on psychodynamic therapy. Am I right if I rack my brain back to undergraduate that psychodynamic therapy was sort of one of the first, founding talk therapies that humans developed?
Yeah, it would have been like the talking cure, really. That was sort of what how I think it was initially it was Freud, and then there's the history of psychodynamic therapy is quite interesting as well. And includes attachment theory as well. The other thing I'd like to leave people with was sort of just coming back to my sort of final comment just now, was that in the spirit, I think, of this podcast and us being human, is that, sometimes we don't always get it right in therapy as well. And that applies to, this model as well. And that the idea of sort of repairing ruptures, I think it's quite a prominent one in psychodynamic therapy. And it's okay for us not to get everything right or perfect. And it's okay for us to inadvertently make mistakes sometimes, because often we can repair those. And I think that we are often under so much pressure as therapists to do the right thing, be the right person. And we are not going to always be that for everybody. And sometimes we will do actually all of the right things, and it won't feel like the right thing for the client because they're wanting or hoping for something different in that particular moment, or their mind space will be that they're less receptive to hearing what we have to offer on a particular day. And so there may be times in therapy where the relationship doesn't necessarily feel as solid as we want it to. And going towards that with clients and noticing our observations or hesitations in the client, or anything that we can see that maybe we're often reluctant to do that because we want to get it right, can sometimes be really, really helpful. So in terms of the therapeutic relationship, being open to, I guess, being quite transparent, and even that kind of, how are things going here? And being open to what they say.
Being comfortable with being uncomfortable, and having, addressing the elephant in the room, the unspoken whatever it is that's going on, is important in psychodynamic therapy, and probably for all of us, to be doing that.
And it's hard.
And repairing the ruptures is really important. All of this is important. I feel like every supervisor I've had has taught me all of these principles at one point or another. It's almost like it's like, to my knowledge, none of them trained in psychodynamic therapy, but maybe there's this sense that these are all really important tools for us, because what we are doing is we are enacting change in people through relationship.
And that's the most effective part of the of therapy is the relationship. And that's why I think I relate to psychodynamic therapy so much, is because a primary component of it is the therapeutic relationship. We're working in the relationship. The relationship is the therapy.
Therapy. Yeah.
Yeah.
I wanted to say, like before we finish, you and I spoke about off air about how if we have any listeners who want to use these podcasts for CPD, you know, if you do want to record in your CPD log that you've listened to any of our episodes, you can do that. And it is just important, though, that you sort of write a little bit of a reflection journal on you know, what you've heard from today and thoughts that you're having and how you're reflecting on your own practice and your own experiences as a result of what Claire and I have shared with you today. So we just want to encourage you to do that.
Yes, and we'll be putting together, maybe it will even be published by the time you actually are listening to this, by the time this one's live. We'll be putting together a resource on our website whereby you can download some reflective questions, so that you can, which will be fairly consistent questions that you could use for any kind of PD, whether it's reading book chapters or listening to podcasts or webinars, the types of questions that you're expected to reflect on. And so that will give you some kind of guide for how you can really make the time count.
Yeah, thank you, Claire. Will we leave it there?
We will leave it there. Yes.
All right. Such a great episode. Thank you so much. I learned so much, and I also feel very validated that, you know, I'm sort of on the right track. And even though I haven't had formal training in psychodynamic therapy, the principles of being ingrained in me through my previous supervisors, and it's definitely helped me a lot, I feel like.
Yeah, I think I'm hoping this isn't brand new for a lot of people, for everybody. I'm hoping that people will say, oh yeah, this feels familiar. Yeah. And now there's a little bit of theory to back that up.
Thank you for tuning in today. If you enjoyed this episode, please take a moment to leave us a 5-star rating. It really helps others find the show. And don't forget to follow us on Instagram at Between2Psychs for more updates and resources. For more information and to explore everything we offer, head over to our website, between2psychs.com.au. We appreciate your support, and we'll see you next time.